Bismillahirrahmanirrahim. Due to some reason, our previous Zoom meeting could not be recorded. So I'm just going through the uh, the content once again on my own. And today we covered as negative symptoms, and in the next session we covered the monitoring of antipsychotics, especially. So negative symptoms we covered today were primary, which happen from the beginning of the illness or in a prodrome, and the secondary, which happen over the course of time and may also be due to depression, extrapyramidal side effects, or due to alcohol or substance misuse, or due to social deprivation, etc. Four A's for negative symptoms are evolution, which is also called abulia, amotivation, and alogia, and affective flattening and autism. Now, which antipsychotics to be given for negative symptoms? So it is said that clozapine, amisulpride, and cariprazine are very important, and followed by olanzapine and quetiapine, and followed by risperidone. For users who have just joined, it is just a recap because the previous thing could not be recorded. So that's why I'm just recording it again, and you can benefit from that. So followed by then risperidone, augmentation with aripiprazole is also, it can be done, and then maybe augmentation with cariprazine, but we don't have that much evidence about that, but that can be thought of as well. Non-antipsychotic options, they are still under research, and it's just mention of the memantine, glutamate agonists, topiramate, COX-2 inhibitors, selegiline, etc., etc. The only evidence would be for SSRIs, because especially if the patient is depressed, then they may work. Non-pharmacological interventions, RTMS, there is some evidence that it works. For ECT, there's no mention. Transcranial direct current stimulation doesn't work. Now we come to the topic of monitoring in schizophrenia. So U&E, which is urea, creatinine, and electrolytes, and EGFR. They have to be monitored. Everything should be monitored at baseline. That's one rule. So this is baseline, and then yearly monitoring in schizophrenia for urea, creatinine, and electrolytes, including EGFR. Baseline and then yearly, especially if the drug is renally excreted, then do it more than more often, and keep a close eye, especially with amisulpride and in mood stabilizers in case of lithium. Similarly, full blood counts, or CBC, complete blood counts, do it FBC baseline and then yearly. But in clozapine, it's a special protocol, and it has to be done weekly or fortnightly or monthly. Apart from that, it yearly should be fine. Um, with the sodium valproate, FBC monitoring is a good thing because it can cause thrombocytopenia. Similarly, with carbamazepine, it can also cause something like the agranulocytosis. Lipid, uh, thanks for joining. It's just a recap. The lecture happened about the 1 hour ago, not recorded. So I'm just recapitulating it, and you can listen to it. Hopefully, the recapitulated version will be uploaded on the YouTube. So then the lipids and weight, it should be at baseline, then 3 months, and then yearly. But if the patient is on clozapine or olanzapine, check it 6 monthly. So 3 months in the first year, and then after that, check it every 6 months, or at least do it 3 months in the first year. Glucose and HbA1c, again, uh, the rule of thumb is of the baseline, then 1 month, then every 6 months. Uh, Otherwise, it's yearly. But in case of clozapine, chlorpromazine, and olanzapine, check it every 6 months, more often than other. For all other antipsychotics, it is 1 year, but for clozapine, chlorpromazine, and olanzapine, it is every 6 months. ECG, check at baseline, and uh, then do it yearly, or if you are changing any dose, then whenever the target dose is reached. So check the ECG whenever you're changing the dose, and then yearly. More be kind of more cautious with the haloperidol, ziprasidone, and quetiapine. Blood pressure, check it at baseline. Check more frequently with dose titration, and then at least do it yearly or whenever the patient comes to the outpatients. Uh, with blood pressure, we should be cautious of both hypotension and hypertension. If we are starting the uh, uh, or retitrating the medication, always start low and go very slow. In the beginning, we check more for hypotension during the titration phase, and towards the end, we check more for the uh, for the hypertension. Prolactin, uh, prides and peridones, risperidone, paliperidone, amisulpride, and sulpiride, they are more associated with hyperprolactinemia. And then we check it at baseline, and then 6 monthly, and then yearly. But especially more close monitoring should be like with other drugs. If we don't check, that's fine, it won't cause any damage. But with the prides and peridones, we should be uh, keeping a specific eye, close eye on prolactin levels. So baseline, then 6 monthly, and then yearly after that. First generation antipsychotics can also cause hyperprolactinemia, and one of the complications of hyperprolactinemia is osteoporosis. So it is worth doing DEXA scan in patients in whom prolactin level is consistently high, and also consider aripiprazole augmentation or aripiprazole adjuvant therapies, because aripiprazole will bring down the prolactin levels somewhat. LFTs, do it more closely with clozapine and chlorpromazine. With all others, baseline and then yearly is fine. And valproate is one mood stabilizer in which you need the LFTs. Similarly, uh, lamotrigine and all other things, you have to check the LFTs at baseline anyway. And combination of valproate and lamotrigine can cause an interaction. So be very slow in titrating up lamotrigine if the patient is already on valproate. So you need even half of the normal titration doses in that case. ADHD meds, worth checking the LFTs, atomoxetine, methylphenidate, especially atomoxetine. And in antidepressants, agomelatine requires LFTs monitoring, and it's written in the BNF. CPK, it's good to check at baseline, and then whenever you are suspecting the NMS or neuroleptic malignant syndrome, it is worth checking. So this is what was covered in today's lecture in a nutshell, and I hope that this recording will be uploaded safely onto the YouTube. Thanks for listening. Dr. Anup, Dr. Anup, you have any questions at all?
No, sir, it was useful, very useful, sir.
Thank you. Bye bye.
Thanks.